Hi everyone, today I am giving you information on the topic hyperopia. So let's move to its description. It is a condition in which the parallel rays of light coming from infinity are focused at a point behind the retina is known as hyperopia or hypermetropia. So let's see. Here the parallel rays of light are coming from infinity. They are focused at a point which is behind the retina and the image is not formed clearly because in normal condition the image have to be formed on the retina. So the parallel rays of light coming from infinity focused at a point on the retina, but in case of hyperopia they are focusing behind the retina. Another name of the hyperopia is the hypermetropia as well as farsightedness. It is known as farsightedness because the person is able to see the far objects clearly as compared to the nearby objects. Next one, components of hyperopia. So first one is the total hypermetropia. Somewhere I have used the word hyperopia and somewhere I have used the word hypermetropia. Both are one and the same thing. So total hypermetropia is equals to the manifest hyperopia and the latent hyperopia. Manifest hyperopia is the manifest which we can able to see, and the latent hyperopia is the hidden hypermetropia. Okay, and another one, manifest hyperopia is again divided into two parts. First one is facultative hyperopia and the second one is absolute hyperopia. So let's see one by one. Total hyperopia, it is the total amount of the refractive error which is estimated after a complete cycloplasia with atropine. Now the person needs to be dilated to see the total amount of hypermetropia. Okay, so the dilating drops are, which are known as cycloplegic drops, are atropine, homide as well as cyclopentolate. So all these three drops are used. For the complete cycloplasia, atropine is used. Mostly it is used in children, and in case of adults we can use the homide. In children we can also use the cyclopentolate also. It depends upon the different conditions. Next one, latent hypermetropia. So the latent hypermetropia, it implies the amount of hyperopia about the one diopter which is normally corrected by the inherent tone of the ciliary muscles. As we all know, what is the location of the ciliary muscles? The ciliary muscles are attached to the zonular fibers which are attached to the lens. Okay, so the ciliary muscles helps the lens to accommodate at the various distances, so the person will be able to see. So latent hypermetropia is a kind of hypermetropia, is a kind of hidden metropia which is corrected by using the ciliary tone of muscles. Whether the patient is not be dilated, then we are not be able to find it. If the patient is dilated, in the dilated condition only we are able to find that the patient has a latent hyperopia. That is why it is known as a hidden hyperopia. Degree of latent hyperopia is high in the children. In case of children, we will get to know that the person have this power but not the correct power. Correct power we can find it by using the cycloplegic drops only, because it is a very high in the children, so we are able to see that the patient is hyperopic, but how much, the correct information is given by the dilated refraction only, and it gradually decreases with the age. As the age of the person increasing, the latent hypermetropia decreases because the ciliary muscles will not be that strong so that they can accommodate at the various distances. They starts losing their ability. That is why it is not be able to find out at the adult age. It is disclosed when the refraction is carried after abolishing tone of the ciliary muscle with atropine. So until the patient is not in a dilated condition, we are not be able to find the latent hyperopia. Next one is manifest hyperopia. Manifest hyperopia is the total remaining portion of the total hyperopia which is not correcting by the ciliary tone of muscles. So it is that kind of hyperopia which is not corrected by the ciliary tone of muscles. It consists of two types. First one is facultative hyperopia and the second one is the absolute hyperopia. So let's see. Facultative hyperopia, it get covered by the accommodation. Accommodation is again the power of the lens to focus at the near distance. Mostly we can use the near power. Mostly we can use the accommodation power for the near. We will stretch our eyes and do accommodate while looking at the nearby distances mostly, and we can also use it for the distance also. Sometimes person needs to be dilated to measure the total hyperopia, so we will find out the total hyperopia in a dilated condition, but it get covered by the accommodation if it is facultative hyperopia, so there is no need to wear any kind of glasses. Next one is absolute hyperopia. Absolute hyperopia is a manifest residual part of the manifest hyperopia which is not corrected by the patient accommodation. Patient can accommodate more and more but it doesn't get covered. So Wearing of spectacle is compulsory, used to give the clarity to the nearby objects. Next one is classification. Now on the basis of axial length. Axial length is too small. Axial length means it is the total length of the eyeball. Anterior posterior length of the eyeball from the cornea to the end to the retina. It is the anterior posterior length. So this length becomes too small in case of hyperopic patient. If the person is more hyperopic, for example, the patient has a +11 power, so the axial length becomes too small. If it is due to the axial myopia, axial hyperopia, refractive hyperopia, so the system is too weak for the axial length. As the axial length becomes too small, okay. So let's see an example. If the patient is very much hyperopic, normally the axial length should be at there, okay. So if it is a normal axial length, so the image will be formed on the retina. But in case of hyperopia, the axial length becomes too small, due to which the image is not forming on the retina, okay. So this get a great impact on the axial length, and due to which the person becomes hyperopic. Index hyperopia. In case of index hyperopia, refractive index changes. It gets changes due to the acquired cortical sclerosis. Sometimes the cortical cataract and the different types of cataracts are also there, which affect the lens refractive index, due to which the person becomes more hyperopic. In case of nuclear sclerosis, person become myopic, and in case of cortical cataract, the person becomes hyperopic, okay. Next one is curvature. Radii of the curvature is too flat for the cornea, lens and other refractive surfaces. So if you can see that this one is the cornea, and the cornea becomes too flat. Due to the flattening of the cornea, person becomes hyperopic, and due to the flattening of the retina, because the axial length is small, the person becomes hyperopic. This is the effect of curvature. Next one is anterior chamber depth. So here it is a decrease in the anterior chamber depth. AC begins from the last layer of the cornea to the starting layer of the lens. Last layer of the cornea is endothelium. From the endothelium to the anterior capsule of the lens, it is a AC depth. So in this case, the AC depth become decreases. Normal AC depth is 3 to 4, so it becomes less in case of hyperopic patients. Now according to the amount, very low hyperopia is plus 0.25 to plus 1 diopter. It is a very low hypermetropia. And low hypermetropia is plus 1.25 to plus 3 diopters. Medium is plus 3 diopters to plus 5 diopters. More than plus 5 diopters, it is a high hyperopia. And next one is the pathological hyperopia due to the pathway. First one is the deformational, short axial length, as I have told you, short axial length. But in this case, there is a pathological, like microphthalmos. So microphthalmos is a condition in which the size of the both eye is different. If you can see in the picture that the size of this eye is very small as compared to this, okay. So here the cornea becomes very small. Due to the small cornea, the eyeball becomes very small and the person becomes hyperopic. And we are able to see, we have to see that is the vision is improving or not in these cases. Next one is optic edema. As you know that the disc is present in the retina, so disc edema will be there. Sometimes disc edema is responsible for causing the hyperopia also. Next one is aphakia. Aphakia means absence of crystalline lens. So in some cases there is absence of crystalline lens. While doing cataract surgery, some complications occur, due to which we have to keep the patient aphakic for the some time, and then we will implant the lens. So in case of a aphakic condition, the patient becomes hyperopic, more hyperopic. So we can take the vision of the aphakic patient with plus 10 to plus 12 diopters. Dislocation of the lens. Next one, if the lens become dislocate. For example, it is seen here that this one is the location of the lens, if you can see, and it is held by the zonular fibers. Now in case of here, due to any kind of trauma, the position of the lens changes and it comes forward, and in this case the lens moves backward. Sometimes trauma occurs, due to which the lens becomes at the posterior, lens move posteriorly or lens move anteriorly. These are the traumatic conditions sometimes, and while doing the cataract surgery this happens, Okay, so dislocation of the lens is also responsible for causing the hyperopia. Next one is symptoms. What are the symptoms? Blur near vision. Patient always complain that he or she is not be able to see the near words clearly. Or asthenopic symptom due to near work. Patient will say I am doing the near work and the and the letter starts jumping from here to there. Asthenopic symptom, I feel tiredness. While looking continuously the near object, it becomes blur. Intermediate sudden blurring of vision. The patient will feel that sudden blurring of vision and then blink the eyes, then it will become clear sometimes. These all are the symptoms. Next one, signs. Eyes appear normal or small. Eyes maybe appear normal or maybe appear small as compared to the normal size. AC is slightly shallow than the normal. Anterior chamber becomes shallow than the normal. Narrow angles. The angles which we can see are the narrow. Disc may be small. Optic disc, it may be small. Short anterior posterior length. Anterior posterior length is the axial length. Short axial length will be there. Next one, associated problems. Now what kind of problems can see? Recurrent stye. Stye comes again and again. It is a blockage of the glands. So it becomes again and again. It will be seen as a boil on the upper as well as the lower eyelid also. Sometimes it keeps on going and coming. Going and coming. Accommodation convergent strabismus. Patient can accommodate a lot, due to which the convergent strabismus will be there. Misalignment of both the eyes, and you can see that the patient is looking at the nearby objects. Both the cornea will be converged and can see nasally. Okay, esotropia you can say. Amblyopia means the power of the one eye is different and another eye is different. For example, the power of one eye is +1 and one eye is +3, and the vision, there is a vision difference in between both of the eyes. Okay, for example, the one eye is going 6:6 and the another eye is going 6:18 and not improving further. There is no abnormality in any of the part of the eye. Predisposed to the primary narrow angle glaucoma. Narrow angle glaucoma may be there because there is AC is very shallow. Next one, treatment options. What kind of treatment options are there? First one is spectacle. We can begin always from the spectacle, can give spectacle power to the patient. Next one, if the patient becomes more hyperopic, like +11, +15, so we can prescribe the different kind of lenses to the patient, like aspheric lenses, high index lenses. But if the patient is not be able to wear the spectacle or not interested in wearing the spectacle, then can switch to the contact lenses. So contact lenses can easy to wear as well as removal, because it gives cosmetically good view to the patient and no thickness like the glasses can be seen. Other, by seeing the other advantages also, can prescribe the contact lens. It is another option. Third one is the refractive surgery. Patient can also go for the LASIK, but mostly the LASIK is done in the minus myopic also. Laser thermal keratoplasty, if there is a difference in the cornea, and keratoplasty can also be done. Next one, phakic IOL implantation. In case of phakic IOL implantation, the cataractous lens can be kept at its place. The crystalline lens can be kept at its place. Here the new lens ICL will be implanted, as the patient has +1 hyperopic. So by calculating the value, that valued lens can be placed here. One lens is already inside the eye and the another lens will be placed here. This is known as ICL. Okay, so when the patient gets cataract, this lens remove first and then this lens will be removed secondly while doing the cataract surgery. This was the end. Thanks for your patience.